I think given it's 4 minutes past five, I think we can get started. And I'd like to welcome you all to the COVID-19 and vaccination rollout in Melbourne's north, an update for business. This is a short session designed to inform participants about the current state of COVID in the north. Also the roadmap out of lockdown and what it means for business and industry, and vaccination requirements for workers and business. Please mute your microphone if you're not speaking, and note that this session is being recorded. If you don't want to be recorded, let us know and we'll chop you out of the recording. My name is Chris James, Executive Director of Northlink. I'd like to begin today by acknowledging the traditional owners of the land on which we meet today. In my case, it's the Wurundjeri Willem people. I'd also like to pay my respects to elders past, present and emerging, and welcome any First Nations people with us today. I'd like to also thank all health workers for their efforts over the past 18 months. Our Northlink partners we work with at Northern Health and DPV Health, and their gargantuan efforts in testing, vaccinating and looking after COVID patients. We're also acutely aware of the efforts going on at Austin Health, and at others in the north as well, including our council partners. I note that the idea to have this session came from Peter McWilliam and Andrew Williamson at Northern Health, and I thank them for their work in helping put this together with Philippa Harding from Nephew. I also acknowledge the Honourable Frank Maguire, MP, Member for Broadmeadows, Siva Sivaraja, CEO of Northern Health, and Sally Curtin, CEO of Bendigo Kangan Institute. Also our speakers tonight, Professor Paul Johnson, Director of the North East Public Health Unit, Dr. Joseph Lawrence, Executive Director, Industry Recovery Engagement from the Department of Jobs, Precincts and Regions, and Don Tidbury, CEO, DPV Health. Finally, Madeline Flynn, Director, Infection Prevention at Northern Health. Please post any questions after the speeches in the chat. If we're unable to answer during this forum, we'll follow up with a Q&A pack. So it's now my pleasure to introduce our first speaker, Professor Paul Johnson, Director, North East Public Health Unit, to give us an update on the COVID situation in the north and some recent changes to the way we manage COVID that have impacts for business. Over to you, Paul.
Thanks very much, Chris, and good afternoon, and thank you for coming to listen. So look, I just thought we're almost in the festive season, so maybe we'll just do a bit of a year in review. So if you think about 2021 and COVID, at the beginning of this year, the Northeastern Public Health Unit was absolutely brand new. It had only one employee, which was me, and we set out to develop nodes at Northern Hospital. So there's a NEFU at the Northern Hospital, and there's also one at Eastern. So we call that NEFU at Northern and NEFU at Eastern. And we also have Austin Health as the lead organisation hosting NEFU. We were one of 9 public health units which were created in response to the overwhelmed situation that happened last year with Wave 2. Where there had been only one central system which just wasn't able to cope with the huge demands upon it of this new pandemic. So at the beginning of January, we were in a very happy place really in Victoria. We were disease-free, it was summer, and there's clearly a seasonal situation with COVID, and you can see that from looking at the Northern Hemisphere news, that as they enter the winter in the more temperate and colder parts of Europe, they always seem to have problems, and Victoria's always had more problems than either New South Wales and particularly Queensland. So you can see that it just seems to be easier, even with the Delta strain, to control COVID in Queensland compared with New South Wales, and probably New South Wales, they found it relatively easier compared with Victoria. So there's some kind of thing that we do in winter, or something to do with the way the virus survives in the colder air. We don't really know, but there's certainly a strong seasonal effect. So there we were in summer. We had no COVID. We were fully open. We were preparing our new public health units to try to combat and eradicate and eliminate COVID when it reappeared, as we expected it would. And also we were beginning the long road of vaccination. So instead of having only public health and social measures and test, trace, isolate and quarantine as our only weapons, we now had new things that we could do to protect our population. And finally, from the experience from the previous year in the hospitals, instead of having no treatment, there's now 3 or 4 new things that we can do with evidence behind them to help people with COVID who do get admitted. Once upon a time, it was only oxygen, but now we can also use 2 or 3 other treatments, which improves chances of survival and reduce the risk of being admitted into intensive care. So as the year went by, in autumn, we were pretty much constantly attacked from our neighbours in the north with introductions of new COVID infections, but also new strains of COVID. So the first new one was the British strain we called Alpha, which definitely transmitted better than its predecessor. So once Alpha arrived, we had that in Melbourne around late January, March, early April. It's much harder now to find any Wuhan original wild type strain. So that strain's been eliminated by its successor. And then a bit after that, we had Kappa strain introduced, producing the big city of Whittlesea outbreak, which spread to the city of Port Melbourne. And that actually came to us courtesy of hotel quarantine from South Australia. And in amongst that, which we successfully controlled with intensive work from our new public health units and a couple of lockdowns, we were able to eliminate that once again. And just when we were beginning to rest and recover and, you know, kind of get ready for the next onslaught, Delta came back. There was at least 2 examples where in Melbourne we were able to eliminate small Delta outbreaks. But finally, the big one, which started towards in July and then really got on top of us from August, leading to the pivot where we reluctantly have to leave elimination and move more towards suppression. And that's where we are now. The Delta strain is really almost a different virus from its predecessor. For example, its serial interval, which means the time it takes to start a new generation, is only about 48 hours compared with 5 days for the original Wuhan strain. The famous R number, which is the average number of people infected by a single new case for the Delta strain, is about 8, whereas with the original Wuhan strain, it was really 2 to 3. So even though Wuhan strain was producing its pandemic, if we could move fast and strike, we could control it, we discovered. But by the middle of this year, with the Delta strain completely eliminating its predecessors, it was pretty clear that this was no longer a strategy available to us. But we've been really pleased, and you can see that from the Premier down, about how Victorians have responded now that we've got really excellent vaccines to offer, and we've got really excellent vaccine services. There's been an enormous push to get vaccinated, and we now have almost, I think it's just on 90% of all Victorians have had at least 1 dose. Now, this big Delta wave really started in the north, and we had enormous pressure in the first few weeks on our public health units, but also on our hospitals, Northern Health, Austin Health, to a lesser extent Eastern Health, although Eastern became a feeder hospital because it's got good air control systems. So all of the medical systems in the north started to groan under the pressure of a new type of COVID patient. So the previous year, there had been predominantly older people, particularly high mortality in the residential aged care sector. But this year, most of that group has been vaccinated. So we're seeing the disease in younger people who are unvaccinated. So we have a sort of an epidemic of the unvaccinated, particularly in the north. And these were often younger people. And there were times when the Austin ICU was completely filled with people from the northern suburbs, many of whom were born overseas, Arabic-speaking people, quite disproportionate to the representation in the population. However, even this has turned around dramatically. So due to extremely good work done collectively by the local government areas of the north, the vaccine services run centrally, the epidemiologists at NEPU feeding information back into our local government areas, and then our engagement officers working with other groups of people already working have managed to really turn around what's happened in the north so that there is now a progressive and systematic fall in new cases, even though we're still having hundreds a day. So it seems that we've been able to get the message to the right people have been vaccinated. And although we're still under a lot of pressure, the pressure is beginning to flatten out and even fall a little bit on the northern acute hospital services. And this is predominantly due to this excellent effort of vaccination, but not only vaccination, but also vaccinating the people at highest risk. And so if you look at the data for the Delta outbreak in New South Wales, which was about 6 weeks before us, about 11% of their cases were being admitted to hospital. But already, because we had that delay and we had, even though we're slightly behind New South Wales in vaccination, and they made this huge effort to catch up and get ahead, in fact, we had a hospitalisation rate around 4% in the north rather than 11%. And it's now actually fallen to just under 3%. So at the moment for the Northeastern Public Health Unit, we had around 300 new cases today in our zone. And we had a hospitalisation rate of only 2.7%. So you'll see this in the statistics that the pressure on intensive care is there, but it's not inexorably rising, which is extremely encouraging. And I think this enormous successful, the people of Victoria combined with the services available and this focus in the north where the outbreak has really started has led to this sense that maybe we can decouple cases of COVID with pressure on our hospitals, which is really the good news story for 2021. Now, this is leading to a complete pivot in the way we think about COVID from a public health point of view. If you think about it before, when we really only had elimination, we had extremely tight rules about controlling individuals and trying to find every single case. As we open up, this is just not possible. It's not possible to deal individually with each case, nor is it really needed and nor is it desirable. So I think a lot of people who have learned the rules of COVID from 2020 and early 2021, where it was tightly managed centrally, there was very strict rules that had to be followed, will notice almost a sense of the centre seems to be missing. Where is the public health unit now? And we're pivoting towards a light touch, automated self-help model, trying to change the guidelines and the protocols to match so that schools, residential aged care, other educational centres, early learning centres and businesses which come into have cases of COVID can relatively quickly, easily manage their own outbreaks, partly because the risk of doing real harm in the community is much less due to the vaccination, and partly because the sheer volume will mean that really only a self-help model is actually going to be practical. So I think I might leave it there and see if there's questions or wait for questions when it comes to that part of the night. Thank you.
Thank you very much, Professor Johnson. Very insightful talk. We might leave questions to the end, but if you do have questions for Professor Johnson, please put them in the chat box. It's now time to introduce our next speaker, Dr. Joseph Lawrence. Dr. Lawrence is Executive Director, Industry Recovery Engagement at the Department of Jobs, Precincts and Regions. Dr. Lawrence will provide an overview of the roadmap out of lockdown from a business and industry viewpoint. I'll pass to you, Dr. Lawrence.
Thank you, Chris. Good evening, everyone, and thank you for the invitation to speak to you all. So I'll just do a quick overview of the roadmap from a business lens and what it means, and we'll reserve as much time as possible for Q&A later on. So as you know, probably the biggest change coming in with the 80% setting at 6 p.m. on Friday is going to be the reunification of settings for regional Victoria and Metro Melbourne. So that's probably the most important thing. The other thing is that masks will remain mandatory indoors, but however, it'll become optional outside if you can't maintain physical distance. In terms of working from home as well, you know, work from home if you can, and that's mainly from the perspective of office workers, or go to work if you're fully vaccinated, if your employer wishes you to attend. And masks, of course, is still mandatory indoors. And for non-accessible parts to the public, so let's say the tea room in the office, you must maintain a DQ of 2 for those areas, and manage employer records for vaccination, etc., as required. In terms of most indoor settings, it's opening up and subject to density quotients of 1:4 people. So that's mainly for retail, restaurants, pubs, gyms, hairdressers, etc. And outdoor settings will predominantly be at density quotients of 1 every 2 square meters, and you could have up to 500 where staff are fully vaccinated. Next slide, please. In terms of other key reopening aspects, is the entertainment sector will be able to operate again fully in terms of having seated events and non-seated events, and there's capacity limits that have been applied. We'll share these slides with you at the end so you can read for yourselves in terms of the settings, but there are allowances for outdoor seated and non-seated entertainment as well. And you can have up to 5,000 people outdoors, which is pretty exciting for that sector in terms of business viability. And event sector is, you know, intrinsically tied to the entertainment sector in terms of having festivals and such, and they're subject to the setting, you know, the venue that they operate that event at. And the Chief Health Officer has some provision to grant approval for large, more significant events as well, which will provide some flexibility as we go through. And just bearing in mind, I mean, these are the settings that'll take us through to tentatively up to the 24th of November when we reach phase D of the roadmap, where there'll be significant relaxation. And so this is potentially up to the next 4 weeks, these settings. Next slide, please. Another important change that's happened last week, which was probably went under the radar, a lot of it, because of the announcements around the roadmap, was that there is a change to primary close contacts. And so 7 days isolation if you're double vaccinated instead of 14. And that's if you're not a household contact of the positive case, that is. And so you got day one test and a day 6 test. And if you get a negative result, you can return to work. And I might switch to the next slide. There's also a change to the treatment of close contacts, and in terms of a matrix that's been applied, a risk matrix. So you could decide which one as a workplace you fit into, and not just a workplace as a whole. It could be a large work site where you might have different buildings, and each building might have a different profile in terms of space, how people interact, is it public facing, etc. And so if you're you know, passing through a contact in a just walking by, and then it's a low risk. But if you have medium exposure, then, you know, face-to-face contact, less than 15 minutes, and you've got some provisions there. And it also depends on the size of the space as well. Is it a large space? Is it a medium, small space? Or whether you've had physical contact. So handshaking with someone in a meeting, for instance, would put you in much more riskier settings than you would otherwise. And it's all dependent on whether you're wearing masks or whether you're vaccinated. And so it's basically a traffic light type system. There's a link on the coronavirus website that has full coverage of this and how to work through it. And there's cleaning guidance attached to it as well, so that workplaces can take the onus and follow through. So our advice from the Department of Jobs, Precincts and Regions is to, amalgamate these sort of settings, protocols with your COVID safe plan to those businesses, so they effectively you can understand what the boundaries are, make sure that staff understand what the new requirements are going to be, particularly, into next week as we have more relaxed settings. And next slide, please. In terms of what a checklist might look like in terms of return to work, it's it's about vaccination requirements. It's about checking in. So the QR code system is still very important, and of course the vaccine status is carried through that. If you are public facing, it's an important thing to check for. Face mask requirements, whether you need COVID marshals or COVID check-in marshals, and they're effectively staff members who check whether you're checked in, whether you're vaccinated. And hygiene is, again, very important. And another factor that's coming in is ventilation and airflow. So there's going to be some guidance put out by government in the coming weeks, which will outline some helpful tips on how to minimize the risk through better ventilation and air filtration. However, industry can take their own steps and do their research, and it could be as simple as installing an extraction fan and opening windows in certain settings to improve the air ventilation. In terms of managing COVID-19 cases, that's the new sort of risk matrix that I found, and making sure that workers are aware of these new settings as they re-enter the workplace. It's really important. So I might kill the slides there and then hand back to you, Chris, for the next agenda item. Thank you.
Thank you kindly, Joseph. I think everyone's relieved that we're moving to this phase. And of course, if you do have questions for Joseph, please put them in the chat. Time now to introduce our next speaker, Don Tidbury, Chief Executive of DPV Health, to talk about vaccination and the primary care response. And at Northlink, we're certainly aware of the great work that Don and his team have been doing in the North, particularly around vaccination. So I'll hand it over to you, Don.
Yeah, hi everyone, good afternoon, and it's great to be here today. So look, just a bit about DPV Health. So we're Northern Melbourne's largest community-based not-for-profit provider of health and community services. So these services include COVID response programs, medical clinics, dental services, a large range of allied health programs, community nursing, mental health, children's and youth programs, disability programs, family violence, homelessness, and other programs to support people in our community, and particularly those people who need them most. So look, starting with vaccinations, and isn't it fantastic to see the big lift in vaccination rates? And I was looking at Hume and Whittlesea. Hume, first level of vaccinations has got up to 93.7. That's over and above the state average of 90.6. And Whittlesea's not far behind at 89.7. And then the second vaccination rates for both LGAs are approaching 70%. So a huge increase in the last 4 to 5 weeks. And I think a lot of the people on this screen have contributed to that. So DPV Health has vaccinated about 65,000 people year to date, and we've tested about 120,000 people for COVID. So starting with vaccination first, so we are vaccinating about 1,100 people per day. That's generally over 5 to 6 locations. So our largest vaccination site is our Broadmeadows Super Hub, which is at the Town Hall in Broadmeadows. It's open 7 days a week. We're also vaccinating at a series of pop-up locations across the northern suburbs. So this week you could get vaccinated at the Calcallo Community Hub at 33 Tonyan Road, Calcallo. That's Monday, Tuesday, Wednesday. Or you could also get vaccinated at the Macedonian Cultural Centre this Monday, Tuesday and Wednesday at 512 High Street, Epping. Later in the week on Friday, Saturday, Sunday, we're moving to Craigieburn Secondary College, which is at 102 Hotland Drive, Craigieburn, this Friday, Saturday, Sunday. You can also get vaccinated at either of our medical practices. So these are in Mill Park at 20 Civic Drive, Mill Park, or Broadmeadows at 42 to 48 Coleraine Street, Broadmeadows. Both GP practices, like all of our other sites, offer Pfizer and AstraZeneca vaccines. If you've got people in your workforces that are nervous about getting vaccinated, they can attend any of our sites to receive advice on that. If they're concerned about attending a larger site, they can certainly go to our GP clinics for a smaller, more boutique style service. At all of our sites, we have interpreters that can support people from different cultures and languages. Moving on to testing. So we urge people to get tested if they've got any sort of symptom. Our flagship testing site is at Mernda train station, just on Schrotters Road there. It's testing normally between 500 and 600 people per day. DPV Health also works with other community health organisations under the banner of the C19 network. We provide testing and vaccination services into social housing, manufacturing, airports, the ports, and locations across regional Victoria. DPV Health also provides a range of vaccination and other COVID support services to high-risk accommodation. So this includes social housing, where we can provide a range of social supports, outbreak management, and other services to support people whilst they're in isolation. We support about 800 dwellings across northern Melbourne. It's a really important part of our work. In terms of community engagement, we have community engagement teams out there in the community. They're talking with community groups, education providers, faith-based locations, social housing and shopping centres to get the message out to support people to either get tested or vaccinated. We're also working closely with our great partners, Northern Health, on COVID positive pathways. So we've seconded our own clinicians to Northern Health to support people who've tested positive for COVID in their recovery processes. Look, it would be remiss of me not to mention the fantastic industry response. A huge shout out to the North Eastern Public Health Unit, our other community health partners, Whittlesea Council, Hume City Council, Northlink, and everyone has worked so closely together on this, what for Northern Melbourne has been a pretty effective community response over the last 2 months. If you need to get vaccinated, please ring 1300 DPV Vax, which is 1300 378 829, or with most of our sites, you can also walk up and get vaccinated. So look, I know the numbers, our vaccination rates are getting higher and higher, but it is that small cohort of people who aren't vaccinated who are at so much greater risk of getting COVID. So that's my final message. If you're thinking about getting vaccinated, please do. You can get vaccinated with DPV Health or some of the other partners on our screen. Thank you.
That's terrific, Don, and some great messages there, and amazing work that you've been doing. We're aware of over the past 18 months during this pandemic, so thank you again. It's now my great pleasure to introduce Madeline Flynn, the Director, Infection Prevention, Northern Health, to talk about infection control for business and the health service response. And again, we're fully aware of the great work that Northern Health are doing in this space, and we'll hear more from Madeline. Thank you.
Thank you so much. I appreciate it. Thank you, everybody, for having me. It's great to be here. So I just thought I'd give a little bit of an overview of Northern Health's response to the pandemic and what it looks like on the inside of the hospital, as well as our vaccination program and our testing services as well. And then just some infection prevention tips from a practical perspective on how to keep the workplace safe when we go back into some normality. So at present, we have 4 COVID wards here at Northern Health. That's in excess of 100 patients. So in comparison, about a month ago, we had 1 ward and we had 20 patients on there. So that's that steep incline that hopefully will be a decline soon, as Paul was mentioning. We have a separate COVID ICU and a non-COVID ICU in order to ensure that we can keep our regular business going. We have 3,700 patients on our community pathways. Don mentioned the work that the DPV health staff have been helping us with. It's a massive, monumental task to keep all of our community members safe who are positive and still living in the community, to ensure that they don't get to a point where they need to be admitted into hospital and are unwell. We have about 1,300 patients coming through our testing sites every day. That fluctuates depending on what's going on, but that's a pretty consistent number at present. We are administering sotrovimab, which is a monoclonal antibody treatment for coronavirus in the community setting. So we're running that out of an outpatient service, which has been shown in some studies to reduce the risk of hospitalisation of COVID positive patients by approximately 85% in some cases, which is great. We have our Plenty Ranges Arts and Convention Centre vaccination clinic up in South Morang. We're running about 4,000 vaccines a day at our most. At the moment, we're doing about 1,500 a day, just because, as already mentioned, so many members of our community have been vaccinated. And obviously, if there's changes to the guidance associated with boosters, I'm sure that will ramp back up, as I'm sure Don's aware of as well, ready to get back into it. We also have an inpatient vaccination program. So our inpatients are obviously vulnerable because they are unwell if they need to be in hospital. So we offer vaccinations to them. And we're also working with our local community groups to get vulnerable members of our community vaccinated at our northern site and also at Plenty Ranges. We've done 245,000 vaccines through our vaccination clinics at both Northern and Plenty Ranges, of which some key stats of the groups that we've been working closely with. We've done over 5,000 protection and transport staff. We've done over 20,000 healthcare workers and aged care and disability providers, 8,300 emergency services workers, and about 9,000 at-risk individuals, such as pre-existing medical conditions that were the original group that we did at the start of the phased rollout of the vaccines. We are also working with a few of our community partners to provide specialised services. So we're running the Vaccination clinic, which is a clinic for people with reactions and medical conditions that they'd like to discuss with a medical provider before they have their vaccine or after having their vaccine. We've also just started a new partnership that's very exciting with Sister Hub, which is providing a safe place and a culturally sensitive location for Muslim women to have their vaccines that are private, that are not in our mass vaccination hubs that are very busy and loud. We've also worked with a few food distribution centres and obviously with our community partners that we couldn't have done any of this without you, and also that promotion in our community to really get us across the line. In regards to COVID safety in the workplace, we've been doing it all along. We've been doing these things since COVID started over 18 months ago, and it's probably in the back of our mind that we don't even realise we're doing it most of the time. But definitely from an infection prevention perspective, there are some key things that we can do in the workplace to keep all of our consumers and also our workers safe as well. So getting vaccinated is the biggest one. For those who haven't been vaccinated yet, there's plenty of available appointments across all of our community providers that you can get vaccinated 7 days a week and pretty much any hour of the day at this rate. Utilising outdoor break spaces is a really big one that a lot of workplaces don't really think about. So we think about tea rooms and break spaces and how they're a very collaborative space in the workplace. But COVID really likes the inside, and COVID really likes those enclosed spaces. So it's about utilising outdoor spaces, picnic tables outside, even marquees, as that will significantly reduce the risk of transmission, because that is a highly risky activity, as everybody has their masks off when they're eating or drinking coffee. So thinking outside of the box about what you can do as a workplace to provide a safe environment for breaks. Also, where practicable, meet virtually. So as much as everybody's really excited to get back to the office, I know that in healthcare we're all excited to see everybody again. And you want to be in a room with people and see people face to face, but we're still not quite at that point that we're into those big meetings just yet. It's about meeting virtually, using Zoom, using Teams, just for a little bit longer to keep it all safe. Also working from home and staggered days and shifts. So thinking outside the box, a lot of people think of a business day as 9 to 5. So starting to think about whether there's anything you can do to stagger those shifts to reduce the bulk amount of people in the same place at the same time. Enhanced cleaning, I know we mentioned that a little bit earlier in this meeting, is really, really important. So cleaning those high touch points such as light switches, door handles, the printer is a really busy place for everybody to be. Looking at all those things that are particular to your workplace. So desks, phones, all those things that we're picking up frequently and touching, making sure that we have wipes available and cleaning utensils to be able to keep them clean in between use. Adequate PPE, of course, so where needed, wearing your mask and doing all the mask etiquette that we need. So not reusing a mask, taking it off, and obviously doing your hand hygiene. And also a really important note is ensuring that businesses have the right environment for people to be supported to take leave as well. I know that in healthcare, this is a prime example, I can use healthcare. We've all come to work sick in the past. We've all felt a little bit off, gone to work, said, oh, I'll be fine. I'm not, it's the healthcare worker term, I'm not dying, I'll be fine. So it's not about that. So with COVID, it's the littlest symptom, being able to go home to. So just those mechanisms to keep in place, the ability to work at home if you're unwell, and then obviously go home and get tested and really build that culture of being able to get tested and not being worried about that from a workplace perspective. And then the biggest one is cough etiquette. So making sure that staff are aware that they need to do cough etiquette, hand hygiene, coughing and sneezing into your elbows, those things that we've seen on billboards since the start of the pandemic. But these are all really key items, and there's also information on the Department of Health website and posters to remind these people of key principles of infection prevention in the workplace. And that's all I've got. If anybody doesn't have any questions, we'll leave it to the end.
Thank you kindly, Madeline, and thank you to all of our speakers. And again, I reiterate our thanks to all healthcare workers who've been serving the community in this time of COVID. It's time now for questions. I invite you all to put your questions in the chat and I'll read them out. I do have an initial question about booster shots. And we do understand that the first wave of those who were vaccinated, particularly healthcare workers, some were fully vaccinated by probably about April this year. There's a view that booster shots are necessary for some categories of people. What is the scenario there, and if so, when would booster shots be available?
Thank you for the question. Boosters are very topical at the moment. So already boosters are recommended for people who've been fully vaccinated but who have a medical underlying immunodeficiency of some kind. That could be because they're on immunosuppressive drugs for various conditions such as rheumatoid arthritis, for example, or they have a malignancy and they're undergoing chemotherapy, or they have a transplant and they need to take immunosuppressive drugs. So that you already qualify and strongly recommended to get that third dose. and with the recommendation is with an mRNA vaccine, either Pfizer or Moderna for that. It's becoming clear from two sources really. One is that in Israel, they very quickly vaccinated their entire population really before they got hit, and were able to keep the disease under control, but now noticing return. And so they are revaccinating or boosting their population. And they've noticed a progressive decline in prevention against infection as time goes by. After about 4 to 5 months, people's risk of infection starts to rise. But the defense against severe disease persists much longer than that. So it's not exactly an emergency yet. But the studies from Israel show that when you have that third dose, you get an enormous surge in your immunity and a 10-fold reduction in even infection, let alone severe disease. So highly effective. So in Australia, we're immediately going to our immunocompromised population right now, available right now, but we'll soon go to the higher risk people who are more than 6 months out, which would be residential aged care, Tier 1A workers, healthcare workers, and then through the entire population in a sequence, with the most recently vaccinated not needing something until later, probably during next year. Now, will we need yearly boosters is not known yet, but certainly we're going to need something, but it could be that that third booster gives you such strong response that could be all you need for some years, or it could be a flu shot type situation where it's annual, but we don't know that yet. Thanks.
Thanks, Paul. We have another question. What about vaccinations for children between the ages of 5 and 11?
So there is already a permission for Pfizer to go ahead and apply to the TGA for a provisional registration for that purpose. So that's sort of a paperwork step away and will be available soon. The question that everyone's asking is how necessary is it? I think in the end, it probably is going to be strongly recommended, but the risk of disease in a child is really, really low. Something like 1 in 5,000 times less likely for a 5-year-old to end up really sick compared with someone over 65. So it's not so much about protecting the children against disease. It's more about trying to keep COVID out of the schools and then having outbreaks of transmission. So it will be available soon, but then how it will be used will be a subject of quite considerable thought, and there'll be recommendations made by paediatricians, the College of Paediatrics, the Royal Children's Hospital, and ATAGI, which I would recommend that you follow once they're available, which isn't quite yet.
That's great. Thanks, Paul. There's room for further questions in the chat. There is also a question that's that I've just received for Joseph about the vaccination of workforces, and we know that employers have been wrestling with the vaccination of workforces, with some people having to be vaccinated to come on site. How long is that likely to be the case for, Joseph? Or is it too early to say? While we're waiting for Joseph, there's another question. Can elderly people have a booster dose before it is approved by the TGA? For example, those in RACFs. Not sure what that means.
Yes, look, an RACF is a residential aged care facility, or we used to call them nursing homes, but it's a residential aged care facility where people, it's now their home, they're living in supported accommodation. Look, at the moment, the strict answer to that is you have to wait for the recommendations. So for example, a couple of weeks ago, well, not, maybe a month ago, you couldn't go along and say, I'm immunocompromised, I want a booster, but you can have one now because it's been put forward as a policy. The same sort of rules sort of apply to GPs, for example, who might be providing vaccination scripts in residential aged care. They do have to have support. This is now the right thing to do. And part of that's been making sure that everyone who needs the first vaccine is done, you know, and everyone who needs the second vaccine is done. But this will come about very soon. So there's not practically much time to wait. And also in an outbreak, it's already available. So if there's a residential aged care where there's an outbreak occurring, it can be then used straight away right now to protect people who are not yet positive if they choose to do that. So I think it's, you know, during the next few days, you're going to hear recommendations and the process will start. But it clearly will take a lot of organisation because there's so many residential aged care facilities.
Thank you, Paul. Any further questions? Okay, there's one here. How do I know when someone is okay to return to work after they have been in quarantine or isolation?
Okay, so the term quarantine and isolation are actually different, and the difference is important. So if you are a case, you are in isolation until you're cleared. Now that used to be a relatively complex process back in the day when we were learning about COVID, and also we were in elimination phase. So you had to have no symptoms, you had to have another test. And some of these things have been recorded actually in old out-of-date protocols. However, we now have a date-based clearance process for cases. So you may leave isolation 14 days after the date of the swab that made your diagnosis without further evidence. So if it's today, that's day 0, and tomorrow's day 1, 14 days later, you're clear. And the reason for that is because that's how within really 7 to 10 days, your immune system has killed all the virus. And then there's a little bit of extra added on, and then you're safe to go out without transmitting it to other people. You do not need a test to clear you from isolation. Now, quarantine is for close contacts of a case. With a person who's in quarantine, they don't have COVID. We're waiting to see whether they will get it and confirming that they haven't got it. So they need a test as soon as they have any symptoms, in case they're developing COVID, even if it's on day 2 of their quarantine. They need a midpoint test. We recommend the midpoint test, like about day 5, day 6, day 7. And the reason for that is if that's positive, then their isolation clock starts early. Whereas if they switch to positive right out at day 12, and that's their first positive test, then their isolation clock has to start from that day. So you end up with longer out of circulation. So if you're close contact, you're in quarantine, you don't have any symptoms, your midpoint test is negative, you get to day 13, you have a negative day 13 test, that's it, you're free. You can go out in the world without further problems or without further restrictions. So it's just important to keep those two situations separate. If you're a case, you don't need another test. You just do time. It's like doing a sentence in jail and then you're released when you've done your time. But if you're a close contact, you need to do your time and have a negative test before you can be released. And that's why we use the word quarantine for contacts and isolation for cases. There have been some examples recently where businesses have been asking people who've been cases to provide negative tests. You don't need to do that. You don't need to have a test to clear yourself after you've been diagnosed with COVID, and you should not be asking your employees. If they've done their time, they come back to work.
That's great, Paul. That clears that one up. We have a question about contact tracing. It
Yes.
says, last week I waited 10 hours on hold for the COVID response team for contact tracing. Are you aware of the process being refined so people do not have to wait for so long? I was a primary close contact.
Yes. So look, this is really the volume problem. When we had 5 cases and we were chasing them down and trying to eliminate the disease, we had hundreds of people on the job dealing with 5 cases and their 50 close contacts. Now we have, you know, up to 2,000 cases a day, and if each person on average has 5 close contacts, that's 10,000 people, and there's just nowhere near enough trained people to deal with them personally one-on-one. So the first part of that relates to what I was saying earlier about self-reliance, understanding the rules and looking after yourself to some extent. So you can, for example, put yourself in quarantine and notify your situation online using an online form to get around the waiting. The other thing that you can do is if for some reason no one ever contacts you, you can do your quarantine, have your midpoint test, and then have your day 13 test and clear yourself. But during that time, it's kind of voluntary in a way. It's not under any legal control. Now, the problem with doing that, if you're not registered, you don't then qualify for any of the special payments that are available. So if you need to get that, then you do need to be registered in the system. But you can, as we say, self-identify online without having to wait for 10 hours. Waiting for 10 hours on the phone is just terrible, and I'm really sorry about it. There's just no really quick solution to that problem just because of the sheer scale of things. So that's why we're moving to automate and streamline the system so that, for example, instead of having to talk to someone to be cleared once you're a case, you've got this date-based automatic clearance. That's it. You don't have to get further communication. Same with your day 13 test if you're in quarantine. Once that's negative, you're out. You don't have to get a letter or anything else from the public health unit.
Paul, another question here. If someone has COVID-19 and is cleared after 14 days, is this still safe to leave, even if other household members are COVID-19 positive and still in their 14-day period?
Yes, because if you have recovered from COVID yourself, you've developed an immune response to it and you've killed the virus yourself, and you are able to resist new infection from your household members for a while. Now that a while is a little bit debated, but it's somewhere between 3 months and 6 months is where it sits. So in Victoria, we've been using 8 weeks with some recommendations for 3 months. Nationally, it's regarded as 6 months. So we won't get into the exact detail of how long, but once you've had COVID and you've done your time, for a period after that, you are immune. So you can safely walk around and not be regarded as having to go back into quarantine until if you meet someone else, e.g. your household member.
I have another question. Thanks, Paul. If someone that is unvaccinated or partially vaccinated gets COVID, will they still need to get their double vaccination?
Yes. So the advice for that has recently changed. So if, let's say you've had no vaccines and you have COVID, when you're feeling better and you've recovered, book in for your 2-dose course. And it's recommended you start within 3 months. But as soon as you feel ready is the new recommendation. As soon as you feel well enough and you've been cleared, you can't go down to the vaccine place while you're still infectious, obviously. If you've had 1 dose, the same thing. You get better from COVID, get yourself cleared in that date-based way that we discussed, and then go and have your vaccine as per the normal schedule. And if a booster is offered to you because of your category, take the booster as well.
Thanks, Paul. Another question, again, about residential aged care. In the setting of giving residential aged care facility residents are boosted during outbreak, is consent required, or dose consent for the first and second dose covers the booster dose also?
All procedures involving giving a person something always requires consent. So if you know, we don't do anything to anyone without their consent. If that person is not able to give consent, then we would reach out to their guardians or the people who have legal power of attorney, medical power of attorney. The exact process by which we're going to use vaccines in an outbreak in residential aged care is not clear yet, but it's just an interim allowance, so it could be used without, so permission is there while the systematic process is organised for everyone to get a booster.
Thanks, Paul. One about schools. Is there any special modelling for outbreaks in schools? Are they higher risk environments?
Yes, so you can kind of divide schools now into primary and secondary, because secondary schools vaccination is available and also has been very surprisingly taken up. There's a lot of people who've been vaccinated now. So increasingly and hopefully, you know, systematically, once we get much freer, is that once you're double vaccinated, you won't really be restricted nearly as much. So the basic rules now for secondary schools is that if you're in VCE, we have a special plan which is handled centrally to try to get all of the students in the VCE system through their exams, even if they are caught up in COVID exposures, and that is underway and working well. For the rest of secondary school, there is a new protocol being developed with DET, Department of Education and Training, and in conjunction with the local public health units, but it's intended to be light touch. So rather than open the school and then close it again, it's to try to keep the school open, but just quarantine the smallest unit possible, which will be a class, for example, where a case has been identified. And if people are vaccinated, then the quarantine period will be 7 days. Unvaccinated, it'll be 14 days. With primary schools, because the predominant, well, everyone's not vaccinated in the student cohort, then it'll be the same approach, but everyone would get quarantined for 14 days. So the exact rules vary a little bit, but the principle is that the poor old students need to get back to school for many reasons, including their social development, their psychological well-being, their educational progress. And I welcome the plans to reopen the schools, and I think the overriding principle should be to try to keep them open. And vaccination is certainly helping that in the secondary schools, and will hopefully help in the primary schools later. Now, as to do they generate outbreaks? Well, children, when there's a lot of COVID in the community, it's probably more likely as an adult that you're going to get it from other people in your workplace than from your child. But if the only group left unvaccinated is the primary school kids, then they may well be the way that COVID gets into a family. And now the implications of that are not nearly as bad as they were if all the adults are double vaccinated. But that's the problem, because they're unvaccinated and kids get together and share germs. They are potential amplifiers at the primary schools at the moment, and it's quite a difficult problem to try to sort out how to both keep those schools open and also not amplify COVID in the community.
I do have another one about schools. Will there ever be a requirement for grade 6 students that may be over 12 to get vaccinated?
I think as soon as you turn 12, you can go and get vaccinated. I think requirement's not the right word, but availability is certainly there. And certainly I would, and like all the people I know who've got kids of that age, my children are now adults and have left home, but people I'm working with, as soon as those birthdays happen, they go off and get them vaccinated.
No, that's great. Thanks, Paul. I note that it's turned 6 o'clock, and that's our allocated time for this session. So I'd really like to thank all speakers. Really appreciate you sharing your knowledge and giving of your time to us. I'd like to thank you all for coming. Much appreciated. I certainly learnt a lot during this session. I think we all did. We'll certainly follow this session with an information sheet answering any questions from the chat that we didn't get to today. We'll also circulate Joseph's presentation, which was quite handy, and any other information that would be of use. We'll also provide regular updates through Northlink on vaccination clinics and pop-ups in the northern suburbs. So thank you all again for participating today. I wish you all a great evening. Thank you.
Thank you very much.
Thank you.